MelaMed community, here we are again for Don't Let the White Coat Fool You. I am Dr. Dixon.
And Dr. Norma Mobley, and we're so happy to be back with you again.
Now, what are we talking about today?
So, something that those of you who know me are going to say, what? Not Norma. We're going to talk about AI.
Oh, Lord.
Yes, so I'm not the most technical person in the world. Actually, I'm like way at the caboose when it comes to technology. But I do feel it's quite important that we stay abreast of what's taking place in regard to AI in medicine.
That's right. It is not going away.
No, it's not going away. It's going to affect how we practice medicine.
Sure.
And it's going to affect you as a patient on how you engage with the medical community moving forward.
So let's get into it.
So so for the main thing is, let's say, it's garbage in, garbage out. Right? So who's creating the AI? Whatever their biases are, that's automatically going to be a part of the artificial intelligence. And then as it moves along the algorithm, it just picks up from what's already been placed, like after the seed has been planted. And it does not incorporate what's different about different medical communities or patient populations.
All right, so that's, again, emphasizes why it's important for us to have some representation in the area of AI.
Right, because it's only as good as what the training format is that's creating the AI, and if there's underrepresentation involved in that, then of course what comes out subsequently will also remain underrepresented.
So tell me a little bit about this when they talk about AI will learn you.
Okay.
Have you seen that? Did you find out?
So look, you see I'm looking down in my lap because I got to look at my notes to make sure I give you guys the proper information. All right, so underrepresentation in AI. The clinical data frequently overrepresents white males and Western populations. Consequently, the algorithms may perform poorly in Black patients, women, and other minorities, simply because the data that it receives does not specify clinically with those other populations.
So no matter what, it just repeats itself.
It repeats itself
all the time. That there's underrepresentation.
Right.
It's not going to tell us about us. The same thing in clinical.
Correct.
Where we're doing more for our patients because we have to always be thinking about what else can we contribute to make sure that communities of color are covered.
Right. Historical biases are also incorporated. The data often reflects decades of systemic racism and sexism in the medical care system. For instance, if an algorithm is trained on records where Black patients received fewer services due to a systemic barrier, then the AI is going to interpret that as incorrectly, though, but it may conclude that the Black patients need less care in a particular area. It doesn't mean that they were healthier. It means they didn't have access, so they don't even have the information.
Wow. So we've got to keep an eye on that as well. I have a girlfriend who told me she was putting something into one of the systems. It might have been Chat GPT, that's the only one I know.
Okay.
And she was able to say to it, that sounds a bit like that's a little racist what you just said there. And it responded back to her.
Oh, really?
Yeah, what
did it say?
It said, oh, well, that wasn't the intent, but I don't have that information. Can
See?
you give me more?
Right. So it can only build on whatever was already planted there in the first place.
Exactly. So we have to make sure that we are adding to or giving it additional information so that it can be more specific.
Right.
Yeah.
There can be flawed proxies or matrix in place. So to predict health needs, AI developers often use proxies such as healthcare costs or previous utilization of care instead of actual health status. Right. So again, if the cost for a particular population or community is not as high because it's not being engaged, it doesn't mean they're healthier. It means they may not have had access to the care in the first place.
So how are we going to combat this? Yet another issue for underserved.
We need you scientific minds out there to get involved in that, because that's way over my head.
Right. So you know what? There's so many things that we need to make sure we're involved in, and certainly AI is one of those spaces. And you young folks who are all into it, you all can do so many different things. This is a space for you.
Right.
Yeah.
So in regard to the assistance clinically, like assessing pain, there still are biases involved in that in the AI system. So misdiagnoses of pain and systems, those algorithms are trained based on biased human assessments. And we've already talked in the past about how that takes place in the ER setting and otherwise. In regard to the assessment of pain in certain populations, patient populations. And so we know that there will be a failure, if there is a human failure to recognize pain accurately in certain patients, then artificial intelligence is going to do that as well.
Now, you know, I'm always talking about people getting out here on Dr. Google. But
I can't stand it.
Lord, they're going to be getting out here on Dr. GPT chat.
Or Claude, that's another one.
Oh my goodness. Well,
Okay.
you got to be careful about that, family. You don't want this to become your new provider. We are still here. You still need the human interaction.
That's
You
right.
still need those of us who have gone to medical school for a number of years to help you with your issues. So don't count on that.
And I'd like to believe anyway that there's not a robot around that can help hold down a 2-year-old while you're trying to clean out their ear.
That's right. Not yet.
Not yet, anyway. We might have some job security in that.
Oh Lord. Hope so.
Hope so. So, in processing and deployment biases, so that means where is AI being used? Okay, so think about it. We have an issue of access to good quality care.
Right.
So there's cost involved in implementing AI. So where do you think there's going to be a lack?
Well,
Rural communities. We have hospital
absolutely.
closures, so there's going to be a lack of access there. And then there will be... Exactly,
Right,
exactly. So again, that's going to be a disparity.
Now, we're talking about those kind of things, but then there's always this other issue for people who live in rural communities or live in underserved areas. Where are they putting all these large AI plants? In underserved areas.
They are.
Right. And those plants pull on so much energy. So why in underserved areas?
And
there
there are toxic factors involved with it
and
that are going to increase illness risk.
So everybody has to be aware of that too. Where are you seeing these plants located, and what can we do about that?
And I have people even that I work with that say, oh, I'm not political, I don't get into politics, but those decisions are being made by politicians.
Yeah.
Your local and state politicians, and so your vote is your voice. And that's one way that you can make a difference.
That's right.
Mm-hmm.
So much to learn.
So much to learn. Yes. We'll have more coming to you about this as we learn more about it ourselves.
And I love what you said. Garbage in,
Garbage out.